Ever since starting his career in neurology, Dr. Schmierer has maintained a focus on inflammatory demyelination, but has done research in many different fields, including pathology, pathophysiology, MRI detection and measurement, and disease control in people with MS, and has also participated in investigator-led and commercial clinical trials. He advocates a proactive treatment approach at all stages of MS. Klaus was actually gracious enough to step in and take over this slot because, as you know, we had many adjustments in the agenda today. And today, Klaus will be sharing with us a talk on pushing the envelope at both ends of the disease spectrum, AttackMS and ChariotMS.
We have a slight change of perspective and companies involved. Talking about two trials, and I think it really adds quite nicely to Emma's talk and perhaps can spark further discussion around that. My disclosures. Just to remind everybody what we're talking about in multiple sclerosis, we are obviously not as yet looking at primary prevention, but really what we're doing is secondary prevention, so in people who have just developed the disease to try and essentially flatlining it there. And similar in people with MS who've been quite established, preventing deterioration in those as well. So I think this is really the territory within which we act very generally. Time matters, that's already been highlighted, and many of you are, I think, very tuned into that concept, and if it needs any further evidence, this is from, I think, a single site in Brescia. People looking at their about 1,300 patients population and how they fared in terms of EDSS when they were diagnosed in the 1980s versus after 2006 and 10, and then more recently, where you can infer that what we do as an intervention through early diagnosis and then dealing with symptomatic therapy, I think the introduction of more MS specialist nurses, for example, have contributed probably to the positive outcome that we all have seen with the risk-sharing scheme of interferons and Angiotermer. So all that contributes, but I think disease-modifying drugs themselves also contributed to that. So the motto is treat early, and but obviously with what, and here's the point, which is actually much more a question. It's not so much a statement whether we should straight away start with highly effective treatment or not. But I think the data such as this from a place that Will, who I saw but didn't say hello either, but I have him here on a very positive note from the MS Base Registry, and you can see the drugs that were involved in this in terms of highly effective drugs. Rituximab, we've heard quite a bit earlier, ocrelizumab, mitoxantrone, alemtuzumab, and natalizumab. When you look at the at introducing highly effective treatment, so that's the blue line versus the red line, from their first disease-modifying treatment, from disease onset, at both time points, you see a clear division between these two lines with a much more gentle slope here in terms of cumulative hazard of risk of progression than with baseline treatment or platform treatment. And we can also see that once you have them all on highly effective treatment, you probably get a more gentle slope in those who have started in platform treatment, but you still get a little of a separation, and that I think relates clearly to the processes that Emma referred to that have already kicked in, that are over and above the inflammatory response, the peripheral inflammatory response we're dealing with in earlier MS. Just to say that we are now essentially trying, just to say, when we're looking at these patients here, the average time between diagnosis and treatment was still 1 year. Okay, so this is kind of the mean. When we're looking at early treatment, this is about an average, although I think more recent data are quite encouraging that comes down when you look at surveys. Anyway, so we're trying with AttackMS to essentially push this envelope, as it were, towards much closer to the very early manifestation, and you can read it all on the blog. But it's also now a project, or I mean, I'm sure you're a Daily Mail reader, regular, so you can read an interview recently. I mean, whatever you think about the Daily Mail, I'm not a regular. This is a very nice article by Joe McFarlane. It's all accurate. Anyway, so it all started here, okay, and this is really the beauty of face-to-face conferences, because this was in Baveno. Many will recognize the place. And it takes about 4 years, or is it now 5 years almost, from the idea to the actual study. And I think I can clearly say I'm not sure whether this study would have actually happened without us sitting down there and really coming up with a concept and then taking it further, such that it is now a registered project which is starting to recruit from September, so that's this month. Hopefully next week we're going to be green lighted. And the idea is obviously to start so early, essentially in the CIS stage, or in people with a very early diagnosis of MS. You all know that if you have the right constellation of clinical syndrome plus MRI evidence, that you can diagnose MS there and then, but that only applies to about maybe 20%. That's kind of the early moment, as it were, and the idea very much to try and avoid or prevent damage that goes over and above what we're establishing with EDSS. Okay, so cognitive failings are much earlier, responsible for people getting out of work or not even getting into work, etc. So you're all well familiar with that. So the rationale is very much listed up here. So early treatment has long-term benefits, but how early is early? Can we change current practice to facilitate brain health? And that is actually one of the outcomes. So one of the co-primary outcomes is, can we recruit within 14 days? Then third is highly effective anti-inflammatory treatment, an effective way to remyelinate. So we've heard a lot about technology and experimentation towards the remyelinating process. The question is obviously, is anti-inflammatory treatment in itself a very good way of doing that? And then which compound is the most useful in such a scenario and has no license for the indication, because that obviously makes the case for a trial. And this is from a recent review by Bierhansel in Nature Reviews, and we've gone straight to natalizumab. Now, why natalizumab? Natalizumab has obviously several benefits. A, it's highly effective. B, it develops its efficacy very quickly. When you look at the MRI data, 2003, published in the New England Journal, that essentially flatlines new gadolinium-enhancing lesions within a month, and then on from there. And one of the, I think, downsides of the compound, which is that you have to give it quite frequently because it doesn't last in the system for a very long time, is a benefit here. And that is because in the initial stage, it is often the diagnostic uncertainty that prevents people from starting treatment. And with natalizumab, that is a lesser risk because it's in and out the system within, say, 8 weeks. And so we find that beneficial. We can then obviously switch on to something different as well. So this is the overview. People with CIS or McDonald MS randomized within 14 days. They have to have at least 2 lesions on MRI. We know then they have an at least 80% chance of having MS. They're randomized within 14 days, and then they have 3 MRI scans over 6 months. Our primary outcome is lesion MTR after 3 months. So this is placebo-controlled for the first 3 infusions, and then they all move on to natalizumab. We felt with current practice this can be justified, that we have a 3-month placebo-controlled phase, and we've negotiated with NHS England that all patients are then eligible for treatment after that with natalizumab, or of course with whatever the clinician decides in the interaction with the patient. And that discussion is in the protocol, will start at 3 months. So at this point, people will have that discussion, but what are we going to do after the trial has finished? There's a few secondary outcomes. Obviously, we're looking at serum neurofilament and OCT and visual evoked potentials. We had some feedback from clinicians to make this kind of a viable concept in a very acute scenario. For example, we have removed the CSF as mandatory, so it's at the PI's discretion. And there's also, you're free to use or not, and at whatever time point, high-dose steroids. Again, this is very much a reflection of clinical practice, which is heterogeneous between the centers. Why are you using MTR? Well, MTR is quite an established quantitative MR measure, and as we've shown quite a number of years ago, it correlates quite strongly with myelination. I'm well aware this is not sort of an isolation, but I put it to you that any sort of biomarker will not be a singular reflection of a single tissue subtype in MS. So that's why we've chosen that. As I already said, so hypotheses are it's feasible, it's efficacious, and it is safe. This kind of coincided really now with a survey that Shift MS has done, the well-known network, particularly for people who have just been diagnosed with MS. And so they did a survey, how long did it take for you to get diagnosed? And so we're looking really at these top 30% and hopefully getting a few more referrals through popularizing the study, spreading the information across London and beyond to get the recruitment done. The inclusion criteria are very simple. We had a cutoff here at 45 years because of secondary or comorbidities that are becoming much more common there and potentially interfering with the signal we want to detect, and others are listed. There's only one really relevant exclusion criterion here, and we may have to amend that in the future, but for now we said you should not have more than one chronic demyelinating lesion, so that means a black hole on your MRI scan. All the others are really all very standard. This is London, and these are the 3 centres, Chelsea, Westminster, us at the Royal London, and St George's, and all the MRI scans will be done at Queen Square. After we finally signed the contract, it took a while. Anyway, so these are all the partners involved, and Biogen is kind enough to support this as an investigator-initiated study. So Queen Mary is the sponsor, but Biogen, the funder, and Moorfields are also involved in the analysis of the OCTs. Yeah, this is just the committees. I want to highlight that there's been significant involvement of PPI, so Rachel Horn here and John Myers are both people with MS who've helped us establish the concept in relation to people with early MS. So we had a focus group, and Rachel is also very active on Twitter, has her own following, and does very, very well on that. Now, so she, for example, did this Twitter survey with a lot of responses to that. And this is John. John's actually a cartoon of himself, really. He's a cartoonist, and this is a book which I can recommend. He's drawn and illustrated about his experience of MS. So this is apparently me. And kind of his understanding of what I told him at the time. So it wasn't quite as, as frank, but that's obviously his experience. So there you go. So that relates really to the moment of diagnosis, which I think is something that we are all very familiar with as clinicians, but it is still, I think, a situation that is often more drawn out, right? So you have, MRI, and then you have an appointment, and there's another one, and the MS nurse comes in between. So it's really a drawn out process. But here we're looking at inclusion within 14 days, which means that people are faced with kind of the wave that's washing over them in a much more shorter acute time frame of the emergency department almost. And just useful just to remind oneself that obviously we can all go through these phases of grief or when it comes to a diagnosis of MS, and that's kind of what we're compressing as per requirement. And so it's worth just reminding oneself what is important for the situation, not so much perhaps of the seniors that are sitting in this audience, but more of those who are becoming involved, how to prepare for that encounter, and then how to make that an as appropriate condition, as it were, for diagnosis, because ultimately you want then from the shock and the other sort of responses to it, move on to acting upon that, and this is, I think, why it is important. Now, we're obviously faced with a particular challenge. In England, you've got a 10% level of vacancies, which is a big challenge in itself, but we're still hopeful that we get some recruitment using this card, and or you can also email, so within, inside and outside London, perhaps not from Northern Ireland, but everybody else can really commute. These are patients with their first manifestation. They can easily travel and potentially participate. So, which brings me back to treating early. We were talking about the very beginning of the condition here, but what does treating early really mean? Often enough in the past, 6-8 years, I thought, well, it's kind of the earliest moment is when people actually enter your consultation room. And we're obviously talking here about people who've so far not been involved in trials. Chariot is the study that you can get a little bit of information here, or you can just listen on. Now, the point here is obviously that we have all these drugs and over the years, which is great, but they still exclude a significant proportion of patients. Those from EDSS 6.5, which are generally not treated, at least from EDSS 7, I think generally people are not treated, certainly not started on disease-modifying treatment in the UK. And that covers, a substantial number of patients. Now that's obviously essentially a social, you could say this is a social aspect or perspective. Is it right to establish kind of equity or equality, as it were, across the disease spectrum when mechanistically you can't actually expect any difference? Okay, so that wouldn't make sense, right? You need to have a biological reason to do this, and I think you can obviously look at the homunculus and see that there's a larger hand area than for the leg. Just remember from medical school that over half of your corticospinal tracts terminate at the cervical level, so you may have more redundant supply for upper limb function. This is interestingly a drawing by John Kurtzky, the very inventor of the EDSS, who always felt that the EDSS is not a very good clinical outcome tool. All right, sorry, this didn't really come, but this has obviously been our key outcome parameter in clinical trials ever since I remember. And he threw that notion already down, right? That when you have in principle, random distribution of lesions, and you have longer and shorter tracts, you obviously have more places to hit that with a functional consequence than if you have a shorter tract. And we've sort of picked that up and underpinned essentially what we were now doing in ChariotMS. So it also squared with the James Lind Alliance established multiple sclerosis top 10, so which treatments are effective to slow, stop, or reverse the accumulation of disability. With that, we're obviously also hoping that some of the symptomatic, some of the symptoms improve and would therefore affect these other priorities as well. I think there's a new one underway at the moment. This is from 2013. So this is the study, cladribine, to halt deterioration in people with advanced MS. We already had our 5th investigator meeting of this study just last week in Leeds. Why cladribine? Well, we know there's good evidence from phase 3 in relapsing disease. There's preliminary evidence in progressive disease, particularly from the 90s, 2 studies using a subcut version of it, or sorry, an infusion and a subcut version. It's quite convenient. It has CNS penetrance, and by all intents and purposes, we know it's as safe approximately as the other highly effective treatments. In some respects, perhaps have a little advantage when it comes to COVID vaccinations. It's a right point to thank all those who are supporting this. So first of all, the NIHR, who's kind of the lead funder, but certainly the MS Society, without whose support this would definitely not have happened. And also their US sister in the National MS Society, Bart's Charity, and Merck supplying drug, and the respective logistics, etc. around that, also the placebo. There's just some seed corn funders. These projects take a long time to develop, and that was therefore, without this, essentially this wouldn't have happened. And there's others involved too. We had to produce some preliminary evidence, and this is really from this program. This is, we called this treating the ineligible, as I referred to, people with high disease progression or high level of EDSS. And we developed our own scheme, as it were, based on the oral data using an off-label product. And you can see here easily the reflection of how Mavenclad is now being used. This is not licensed for MS, of course. We produced quite a bit of information available on the internet. So on SlideShare, you can get all the respective info. This was obviously a repurposing effort about which I've been talking back in 2014. And I mean, the industry does this all the time, but it doesn't work so well in academia usually. But here I think we were reasonably successful in first of all, bringing a team together that really spreads across the UK and even beyond. There's Gunnar Yildersen, for example, involved, who has a lot of experience from his hematology exposure and others. And so we've published quite recently these 208 patients and the data. This is, by all intents and purposes, very much audit type of data. You can see that really in the number of cases where we have actually a reasonable data set. So take it all with a pinch of salt. Okay, so the NIDA results are very similar to what we expect with the license preparation in people with relapsing MS. And then we've got NEPAD data with, I mean, this includes NEPAD plus walking test, and this is NEPAD star, which where we excluded the walking test to kind of hone in more to the population that we're addressing in Chariot. And you can see this is, as I said, small numbers altogether, but if you remember the ocrelizumab data in terms of NEPAD, and here it's at least encouraging preliminary evidence, not more. What we've also done is in a subset of patients, we've collected their CSF neurofilament. So this is about 10% of the population. And this is a logarithmic scale, okay? So you can see there was one absolutely excessively high level over 10,000 picogram per microliter, which came down, but not to a physiological level or what we know from our reference population. All others did drop if they were pathologically elevated. All of them dropped after a single course of treatment into a normal range. This is the overview of Chariot. So we're recruiting 200 patients who are randomized to placebo versus cladribine. And then, because we're obviously looking at people in wheelchairs who need an outcome different from an ambulation-dominated EDSS, and that is the nano-peg test. We have a number of secondary clinical outcomes, MRI outcomes. We're also looking here, for example, for slowly expanding lesions. Obviously, nobody has any data in such a population on that. Health economics, or also quality of life of the individual, but also for partners or carers. And then there's some exploratory testing as well. Another element, other than that being focused on people with EDSS 6.5 to 8.5, is that there's no upper age limit. And that was, again, very much a reflection of our PPI interaction, that people felt very much excluded. And we were bang on with our first patient, who's a painter. Okay, so she's very much keen to maintain her upper limb function. And Carol is 70 years old, and she is with her grandchildren. Here's another more recent patient whose hobby happens to be chariot driving. Okay, so there he is with his T-shirt and hopefully driving on. These are the centers. These are actually my trial manager and monitor, Lana and Tanjil, who are very active. So these are now the active centers in green, and 3 to come. If you're active, you'll be delighted to join my WhatsApp list, okay? Being harassed. Thanks very much to, this is obviously the PIs only, right? But they're all fantastic to be involved and proactively recruiting. Here's some of the other teams. So this is the team from Belfast, and some from the Royal Free, and these are from our team. And this is where we are with recruitment at the moment. We have, the last count was 45 or 46, so we're hoping to be at 200 by the end of next year at the latest. So whoever's in the audience, please keep the momentum, because as we all those who are involved in trials funded by the NIHR, they get these nice letters, okay? So current addressing sort of clinical research delivery, and I mean, one of the numbers was 60% of trials that are actually under review. Under review meaning you either continue to be funded or not. As I say, no pressure. They're always mindful or really anxious to tell you that it's not the NIHR, it's actually the Department of Health, Social and Care, with our new Secretary of State, Therese Coffey. It changes quite often these days, just as a reminder. And yes, so keep on referring and recruiting so that that wave doesn't wash over us eventually. So here's at the end, essentially a hypothesis, a bit of food for discussion. Time matters at the earliest detectable disease stage, perhaps even earlier. So talking about RIS or even beyond that, to enable a cure-like outcome or long-term remission. And I think disease-modifying treatment targeting B and T cell subsets matters is beneficial throughout the course of MS. So that's really the hypothesis. With all the caveats and shortcomings, think of that only addressing a part of the pathology. We're very mindful of that. So with that, I'd like to thank you all. This is us at a couple of weeks ago at Regent's Park, so where we are now, on our Way Day. So thanks very much for your attention.